Almost 58 people already joined from Chile, almost chilled winters from north and pleasant from south, west, and east. Everyone has joined. Anil, for to hear you. This is a very important topic. Important topic in the sense when we send our patient at home, patient don't want to go home. They want to stay in the hospital. They think that whatever will happen, it will be hospital will be a better place. But as a palliative care physician, we all know and we have understood by now that home care is the best care in terms of even at an end of life or in terms of symptom management. But many of the times we don't understand how to explain to a patient that how they should take care of their patients at home. So I think the most brilliant person who can explain how to take care of patients in terms of symptom management at home is Anil. I am really proud to introduce Anil at the is the most prominent place of India. It is in IIT Delhi. You know, this is a porch of IIT Delhi. I am introducing you from here, Anil. Anil. Most of the people, those who are here, they know, but new MDs they join this class definitely. They don't know. They must not be knowing that who is Anil Paleri. So Anil Paleri is a very senior palliative care physician of this country given contributed a lot in terms of palliative care growth for whole of the country. He is at present consultant palliative medicine at and clinical director of palliative care services at Kozhikode city, that is Calicut, IPM Calicut. We know he is also consultant WHO Collaborating Center for Community Participation in Long-Term Care and Palliative Care. He is also reviewing many of our articles of Indian Journal of Palliative Care, and he was former director of Indian Institute of Palliative Medicine Kozhikode and WHO Collaborating Center for Community Participation in Long-Term Care and Palliative Care. One more important thing which we cannot forget, Anil, your contribution as an honorary secretary of Indian Association of Palliative Care. You have contributed a lot in the development of palliative care for almost 6 years. And he is also working as a founding trust, World Hospice and Palliative Care Alliance. So Anil, everyone is waiting to hear you. Thank you very much for joining, and thank you very much for accepting IAPC's request to give a highlight how to handle a patient at home. Thank you, Anil.
Thank you, Sushma. Am I audible?
You are audible.
Okay. Thank you.
So you can share screen.
Yeah. Thank you for the introductions. And it's good to see many familiar faces here. I can see Stan. Oh, Rukmini there. Mujib. So many old faces are there. Nice to see you all. Today's topic is symptom management at home. Let me start sharing the slide. Yeah. We're able to see my screen. Is it coming?
Yes, sir. Yes, sir.
Okay, fine. So when you talk about symptom management, symptom management has got an important role in medicine, especially in palliative care, because symptoms is a subjective evidence of a disease in you, or it tells you that something is wrong with your body, and people identify and understand or experience the illness through the symptoms. So even if the curative process is on, or you have taken care of some of the disease process, if the symptom persists, that will not make the patient comfortable. So symptom management has to be very meticulous, especially if there's no curative option and the patient has got advanced disease and the symptoms are likely to persist throughout their lives, or new symptoms may appear at every point of the disease trajectory. That is just to make them miserable and cause poor quality of life. So this is important that we manage symptom meticulously at home. So that's fine, and you know that it's an important aspect of palliative care, symptom management. But when you talk about symptom management at home, um, or when you symptom management during home care, you might ask, what is home? Normally when we say home means it's a place of residence, like it's where one stays, or it can be a rented place or something. But uh, there can be a wide range of things which is kind of home. Sometimes it's just a simple household, or maybe different socioeconomic background. And you can see places like this, or sometimes that this is one place where we found one of our patients. She called it home. Or you can get such different places where people stay, and providing good symptom control in such setup may be very difficult. Or sometimes you can, and you can also ask, is that the symptom management at home is very different from other care settings? Because we do treat patients as outpatient in the clinic or in inpatient clinic, and basically the principles of management or symptoms are basically the same. But that what makes it different from the symptom management at home, different from other settings. Um, this is probably you can get a decent, or maybe a good looking, or a still better place than most household. But on the other extreme, I have recently been to a household where they have set up a mini ICU to treat a person who had a recent head injury. The hospital has set up a mini ICU at home, like a kind of in the transition process. They wanted to start the patient early to home because of the COVID situation. And the hospital has set up an emergency, a kind of a setup with all the reclining beds, oxygen supply and everything. It looked like a mini ICU. So that's also possible. So when we have this kind of extreme situation where like people sometimes stay on the pavement and you provide treatment there, and sometimes we have all the facilities you can imagine, you get a kind of a dedicated nurse at home supporting the patient. Um, it's not a standardized thing like an outpatient clinic or an inpatient unit where you have kind of a regular routine programs or routine process, like you go in the morning and take rounds and then come back and write the prescription. There's someone to oversee your medicine intake, someone to follow up on your activities, someone asking you regularly whether you're fine or not. So these things may not be possible at home. So how can we ensure that whatever we do to provide good symptom control is actually working, and how do you follow this patient? And these are the reasons why some patients are not very comfortable at home, because they are too sick to be kept home. They have very unstable symptoms. They continuously kind of a progressive disease which makes their life miserable, and they probably need someone to supervise them on a regular basis, at least for a few days or a few hours, to make sure that the symptoms are well understood, and then we have given the right medication or right interventions to it. So they are too sick to be kept home. They need to come back to the hospital often. And certain interventions cannot be done from home, obviously, because you need other support staff or other instruments, or other monitoring devices to provide to support you while you do certain interventions. But then again, uh, it's a situation that that demands, or the complexity of the interventions which says that we need a hospital to do this, and sometimes inadequate backup service. When someone is at home, having a chronic illness is a 24-hour affair. They continue to have that suffering 24 hours a day and 7 days a week. It continues. So their symptoms are persistent, and they probably have some new development, like a worsening of symptom or a symptom developing very often. And you need a backup service. Someone has to check on them and see whether they are doing fine. And if it is not possible, then they probably would like to come back to the hospital so that because they feel they are more safe there, or they're more better supported in such environments. No access to care at out of hours make things difficult. Same thing. If something happens in the middle of night, or a pain worsens, or the new symptom develop, uh, whom to ask? Who's going to tell them what to do? And it's a very distressing thing for the family to see someone having a difficult symptom or pain or whatever, and then not able to do anything for him, not able to call anyone for help. So in such situations, again, people prefer to come to the hospital. And at home, family may be preoccupied with day-to-day activities. When they are in the inpatient unit, probably they are free from other activities, so they can turn their full attention to the patient. Feeding them or making sure that he take the medication, everything. Once they go back home, go back to the respective homes, there are other things to attend to, like day-to-day activities of the house, many other things. And probably the patient may be one of the many priorities that they need to look after at home. So the level of attention might come down when they actually go. In fact, what in our experience that people do get better attention home, but it's possible that if it's a single carer or not, if there is no many people to support the patient at home, then this can possible. So these are some of the reasons why it is difficult to keep patient at home and support them. And let us see what are things we can do to ensure that we provide good symptom control at home. Basically, I'm not discussing too much medicine here or too much about interventions or what it is. It is basically looking at how things can be, what kind of support system we need to develop, what kind of, what are the changes probably we need to have in our service to make sure that the symptom control is better. So how can we ensure adequate symptom control at home? What is the home setup itself? When we talk about home, there's a lot of things. And most of these premises, what are the room or the furniture, everything will be familiar to the patient. So, for someone who know where the toilet is, where the wash basin is, or and what kind of structures lie around, and this helps them a lot to understand and to be comfortable in their own home. So home setup is very important in supporting the patient. So the home care team also should know a little bit about the home, so that they can probably help and tell the patient like where the medicine is kept, or all the things that the patient can know, and he can be comfortable with that knowledge. And second thing is who all can be the members of the team taking care of the patient. When we talk about home care teams, it is not just the team who visit the patient once in a day or once in a while. It's a whole team. Like there are people in the institution or wherever the base is, who will be in getting in touch with the patient and following up on them, or making fixing up the appointments or the visits. And the team actually goes there. All the members of the team, including the drivers, nursing staff, and doctors. And we also have people who want to support the patient and family at home. It can be the family within who's staying with the patient, or it can be the immediate neighbors, it can be the friends. And they have a equal interest in patient well-being, if not more than you. They are worried about the patient same as you. You have all the worries will be same as yours. And they are helpless because they probably don't know what to do or how they can help the patient. So if they identify the roles, if you can clearly tell them who can do what, like I have seen in some household that the youngsters, they take care of the role of making sure that the patient takes medicine at regular intervals. And sometimes it will be a friend who's coming and sitting with the patient, or asking the patient if they need anything. Or so you can find people who are supportive to people. And you always should invest on carers or support carers, because they are going to be your best ally when it comes to care at home. And they are going to be there for 24 hours sit-down. Even you go there, visit once and come back, but these people are going to support the patient for rest of the time. So if you invest time, your effort or emotion, whatever, make sure that the patients, that the carers understand exactly what's going on and how they can be useful to this patient. That will definitely improve the symptom control of the patient. For simple things like explaining the need for taking medicines at the right time, or to watch for the warning signs, or all those things you explain to them clearly, they will be following that up because they are also interested in patient well-being. So when you talk about care at home and providing good symptom control, we need someone who's very supportive of the patient, who can follow up the patient on a regular basis and then get back to you, or even help them to have additional support or the measures. So invest on the carers. Then we should see how good is the backup. It's about home care team and frequency of the visit. And we have teams who visit the patients every day. And we also have the teams who visit the patient maybe once in a week or once in 2 weeks. So if the frequency, the interval between the visits is kind of very wide, then the patient and the family may not have somebody to fall back on if they have any symptoms or any difficulties, whom to call or who's going to visit them and support them. So the frequency of visit is very important. So if the home care service is operational in that area, they should have a clear understanding on how soon one need to be visited and how frequently one need to be visited, and based on the symptom burden or the difficulties they have. So there should be a clear planning on features or tubes. Similarly, you can have a priority list or a program where you actually see who needs most of the care and how you can support them. And another thing is the presence of an inpatient or outpatient service nearby. Because I told you this patient's life is not, it's not like a very comfortable trajectory. Suppose the patient has pain. Pain is not static. Even if you take medication, it can worsen at some time. Or even if patient take medicines for breathlessness, it can worsen sometimes. Or they might develop new symptoms. And sometimes it may turn out to be too difficult to be managed from home. Then the patient needs a backup. Sometimes a patient has to come to an outpatient clinic where they have more facilities to monitor or investigate the patient. Or sometimes the symptoms become so severe that it's practically become impossible to manage from home. So continuous symptom control from home will only make the patient's life difficult. So there should be a backup facility somewhere nearby where the patient can go to if the symptom control from home is goes out of control, and they need to be kind of monitored, supported, evaluated, and necessary changes to the management protocol, and they should be sent back home. So this is a kind of a assurance the patient has, so that they can comfortably stay at home, knowing that if there's a crisis or there's a need arises, they can go back to these people or these centers for the support. Then the question is how easy to access. Sometimes because the terrains are difficult, access to the service or the public transport facilities or even the transport facilities are quite. Accessing the support service may not be that easy. That also should be borne in mind when you plan your visits and your management for this patient. Another question is out of our service, like I said, in the middle of night. Because most service close by 5 o'clock in the evening and they open only next at 10 o'clock in the morning. So what will happen to a patient who has a symptom or who needs an assistant or needs an advice on his symptom management in between? What kind of support here? Some of the places have, support service. They have night backup. My city has a night home care service. So if there's an issue in the middle of night, and they will be in that house within half an hour. So this is this will be required if we want to ensure that the symptoms are controlled and they remain under control throughout the day and night. This kind of support. Other option would be to have a backup, a phone support. Now, something that Corona has taught us, the COVID situation has taught us, is that how to do telemedicine. Now, many people are comfortable in calling up the doctor or the service, that health provider, and ask for guidance. And this has become a common thing now. So this is another possibility, to have a support, either online as a telephone line, where the patient or family can call up and ask about what to do next if they have a difficult symptom. Symptoms like take that medication. Like if there's someone has pain and it looks like a breakthrough pain, just someone telling the patient and reassuring that all they have to do is take the next dose of medicine, and how soon they have to take it. This itself might solve the issue. Or if you feel that symptom is severe, what to do next, whether to call up the home care service next day morning, or if it's too difficult, whether to go to the hospital in the middle of night itself. So a support service definitely will help these people. And then I think there are few published articles which say that actually that regular follow-up over the phone is good enough to provide good quality of life and make the patient comfortable at home. Then we talk about medicine, because when we talk about symptom control, we always most of the time we talk about medicine. And you know that oral medications are preferred in palliative care. In situations where the patient needs to take medication on a long-term basis, having injections is not a practical solution. So the patient, as far as possible, they should be given oral medication. This gives a lot of freedom, that all they need is a glass of water and they can take it from anywhere. And they need not be dependent on others for medication. Like if they take a regular injection, say that they have to administer it themselves or ask someone else to help. So this dependency is can be avoided if oral medications are given. And what medicines are available and what kind of materials are available to this patient. Whether the patient has easy access to medication, whether your prescriptions are very, very clear, like they know why these medications are being given, and if they suppose for some controlled medication, some medication they cannot get from, even if they want to buy it from outside, they cannot get it without proper prescription. Availability of medicines is very, very important in the household. Sometimes most often the home care teams themselves provide this medication, but sometimes the patient may have to buy it from outside. But whether it's available to them, it's another question. So whatever you prescribe, you have to also ensure that these medicines are actually available and accessible to the patient. And complaints. We ask them to take medication every 4 hours, like for example, morphine. It's very difficult. Even if you are asked to take medication every 4th hour for a certain liquor, you may forget it, or you may kind of, after a while, you may even stop taking it. Simple antibiotics, and once you start taking antibiotic and you become better, you probably stop, or you even forget to take it. So someone taking medicine round the clock on a long-term basis, complaints can be an issue. So someone should be responsible to oversee that, responsible and should oversee that the patient is taking medicines at the right time. And these people need to be explained very clearly to why these medicines are being given and why should they be. Sometimes like anticipatory prescription can also help. When I say anticipatory prescription, I mean that it's not advised to take on a regular basis, but on certain situations. Like for example, rescue doses. When you advise people to take regular analgesic, you also tell them that if there's a breakthrough pain, if the pain worsens or suddenly he gets pain, the blue, then you can take an extra dose. So that need to be clearly explained, because people are sometimes reluctant to take extra dose of analgesics, saying that it can cause more harm to them, but they need to be explained. Or similarly, in patient who has advanced illness or who are dying, uh, they can have difficult symptoms like too much secretions, or sometimes they can become very, very restless, and what to do in such situation. So you can write a prescription like a dose of haloperidol or a sedative, and instruct the patient and or the family very clearly when to give this prescription. So they have something to use if difficult symptoms arise. And then you have to consider other routes of administration of medicines. It's always the preferred route is oral, but sometimes the oral route is not easy, or the patient cannot swallow the medication. Then what to do? Just to get medication, the patient have to come back to the hospital. If you have a clear strategy of what else you can do, like what other routes of administration, medicine administration can be used, then you can still keep the patient at home and make that person comfortable. Something like sublingual route is very common. Most medicines can be given sublingually, or to the mucosa absorption is there. So one thing you have to make sure when you do such things is that the mouth is really wet, because patient with advanced illness, they often breathe through their mouth and become very dry. And if you place a tablet in a dry mouth, it may remain there without any changes. So when you actually do it, when you actually give a medicine sublingually, you can also put a drop of water or moisten it so that it get dissolved and get absorbed. Or injections. I'll come to the injections in the next session. So that's other possibility, giving medicines by injection, but it is possible to give at injections at home. So that also need to be. So what kind of support will be there at home to provide injections and other. A good way of giving medicines is rectal, but somehow people don't prefer it in our culture. Like administering medicine through rectal route is not very comfortable, or not very culturally acceptable method of giving. Then comes to procedures. Yes, we can do procedures from home. Patient don't have to come to hospital for that. Subcutaneous injections, it's probably one of the, if oral route is not preferred, other routes are not administration is not possible. Subcutaneous is much better than giving medicines intravenously, because it is easy to secure these needles, and easy to give this medication. Only thing that you know which medicine can be given and which cannot be given through subcutaneous route. And in advanced illness, a patient who are dying or have very difficult symptoms, sometimes we even train the carers to give a subcutaneous injection. And I think there is a position paper by Indian Association of Palliative Care on giving injections from home. I think the next session and tomorrow, next week, I think Stan is going to discuss end of life care, and probably it's one of his favorite topics, giving injections from home. So I'm sure Stan will be detailing that. I know that the position statement and what other things can be done at home to give medications and parenteral medication. Then comes subcutaneous infusion versus IV fluid. At home, sometimes we get, sometimes we always patients and family ask for IV fluids, thinking that is actually going to help them a lot. But it may or may not be. There are situations where actually IV fluids are harmful, like a patient having a cardiac failure, or someone having an advanced renal disease, or people having failing systems. And if you give them more fluid, that can be detrimental. That will only increase the secretions and increase edema. That can be harmful. This can be explained. But if the IV fluids or the fluids is going to really help the patient, like someone who is having dehydration, someone having a upper GI malignancy who is not able to swallow, and he feeling thirst and hunger, how to give IV fluids. The traditional and more familiar way of giving IV fluids is through intravenous route. You secure a IV cannula and give fluid. But then at home, it's difficult because it can get disclosed, or there can be infections, or it can bleed, or need a certain expertise to manage that kind of route of administration of fluid. Other option will be to give fluid subcutaneously. It's not that difficult, only that you choose the right needle and right place. The place of administering the fluid is important. You need to select a good site like an abdomen or thigh where there's a lot of, there's a lot of loose areolar tissue, and place the needle in the subcutaneous plane. It should make sure it's not intradermal or intramuscular, and run a fluid very slowly. You can give up to 500 to 1000 ml, maybe over a few hours. But that you need a lot of explanation to do here, because it can cause, subcutaneous infusion can cause some local swelling and some mild discomfort, and the patients and family need to be told about this. Because all they might have seen is that whenever the fluid get extravasated, that the nurse or doctors get upset and they immediately change the needle. So fluid getting out into the subcutaneous plane is not that a regular thing that they experience. So you need to explain clearly what we are going to do, and the advantages and how they do. And the biggest advantage is that it is not it's likely to cause less complications than IV fluids. The chance of infection is less. You have to, of course, you need to inspect on a regular basis, but it cannot get, even if it gets dislodged or if they want to stop it, it is easy, or they can. It's much easier than IV fluids. Then paracentesis and pleural tapping, like removing fluid, ascitic fluid or pleural fluid. It's a bit tricky. Like ascites fluid is one of the common procedure we do at home. Of course, we need to have a clear idea what you are doing. Like you have to consult with a doctor first, and someone should have examined the patient and see and ensure that he actually needs a paracentesis from home. And usually we prefer to do the first paracentesis from institution so that patient is comfortable. They also know what the procedure is and how it is done, so they can go back and do it from home. So if the home care team is well equipped, they can do it from home. And pleural tapping, it's slightly difficult because mainly because of the complications that can arise from that. So normally it is not done, but I've done it once in a patient who is in a remote location. Patient could not be transported, and that also because I knew the patient and the family very well, and because we have been seeing the patient on a regular basis for a long time, and they knew us very well, and they are also comfortable agreeing to for the procedure, and they give consent. So that's possible. Basically, it's a bedside procedure, but it's become difficult because of the potential complication that can arise out of fluid tapping. And there are other incision like nebulization, inserting tube that happens, that's being done on a regular basis. And this thing can be done from home. Patient don't have to come to hospital to change the catheters unless they say some kind of complication, which demands that the patient come to hospital for this procedure. Then you should have a clear distinction between a sterile and clean procedure. At home, doing a sterile procedure is difficult. You need a certain expertise that. Like, for example, taking fluid out of your abdomen is a sterile procedure. You have to make sure that all the sterile precautions are followed. At the same time, dressing a pressure wound is not a sterile procedure. It's a clean procedure. Although you have to ensure that the area is clean, and whoever is doing the dressing follow all the hand washing and other procedures. So that's clean. And people also do things like intermittent self-catheterization. It's actually a clean procedure. It's not a sterile procedure. So they have a clear understanding of what procedures can be done. And a lot depends on the skill of your team and what kind of support you have to do these interventions at home. But if it's possible, if you can do the intervention from home, that will certainly take away the stress of transferring the patient to a hospital, and they can be quite comfortably placed at home. Then preventive measures, when we talk about symptom control at home, we should try to prevent the aggravation of or development of symptom at all cost. It's like prescribing medicines for a symptom which can arise, like a breakthrough pain, or what to do, or where to go if there is a new symptom, like some breathlessness arise. If you expect the patient to uh, develop vomiting following a certain intervention or a certain application of a certain medication, then you tell them what to take. For example, if an opioid naive patient who's taking opioids for the very first time, you advise them also to take a small dose of D2 blocker in the night, like a haloperidol or a metoclopramide tablet at night, so that they don't vomit. Similarly, if you start someone on an NSAID, you also advise them to take PPIs. That is to prevent the gastric side effects. And otherwise, if you don't do that, very next day or the day after, the patient will come back to the hospital with abdominal pain and vomiting. Not all of them, some of them. And the pressure sores and constipation are the two common thing that you can easily prevent. But it's almost like everyone who is bedridden are likely to develop, especially constipation. And mobility is one important factor. Even if you're bedridden, you can ensure adequate mobility with like turning the patient to the sides and or advising what to eat and ask them to take a medication on a regular basis. All the things that are important. So that you prevent this potential complication of symptoms. And preventing infections is another important. These patients with chronic illness often will have reduced immunity. And if you are not that careful, like I'm not that careful, whoever, the visiting teams also, if they're not that careful, you can introduce new infection to them. Especially one procedure I'm pretty much worried about is the changing catheters. Because nowadays you get a lot of urinary tract infection with resistant organisms. So if they develop urinary tract infections, then it's difficult to treat. So you have to ensure, the team have to ensure that they do all this intervention in such a way that they actually are not introducing an infection, or you are not bringing up organism from the patient's body and putting it elsewhere. So it has to be kind of a very meticulous precaution to prevent this infection. And prevention of burnout in the family is another. Looking after someone on a long term is not an easy task. It's a full-time job. So sometimes family actually can get quite upset or burned out. So how to support them? What we do in our place sometimes called a respite care. If the patient is even if they are comfortable or they're doing well, we admit the patient and family for inpatient care once in a while, so that family actually gets some time to rest. Someone else will take care of the daily course, and family have more time to spend on other things. So sometimes I've even a couple of occasions where the patient, there was a big function in the patient family. They decided to admit the patient in a hospice, so that family will be free to take care of that the other social or cultural events that's happening there. So this is important. Otherwise, what will happen that the patient will get neglected over a period of time, and the symptom control will worsen. So, like I said in earlier, invest a lot of time and effort on the family or the carers, so that patient get good quality of care at home. Then we have tubings and other things. We have catheters, different catheters for draining urine, like it's something a bit temporary, or some people do it self-catheterization, sometimes indwelling catheter. And these things can cause a lot of trouble to the patient. Sometimes it's infections which are arising out of these catheters. And like I said earlier, we should take every precaution to prevent infection. But again, when it comes to urinary catheters, you have to really differentiate between active urinary tract infections and bacteria, because simple bacteria doesn't mean that you have to treat the patient. It's bound to happen. Once you introduce a catheter into the bladder, there's likely to have some bacteria. Only if it is symptomatic, a patient has fever or falls in the urine, then actually treat it. Otherwise, just support the patient and make sure that they drink adequate water and maintain clean habits like washing the hands before they do anything with the catheter, or maintain good hygiene. All these things need to be properly advised so that the infection don't occur. Nasogastric tube is I would say, is a kind of a double-edged thing. Uh, it can really help a patient who can't feed otherwise, and uh, make them have good symptom control. Like a patient can take medicines through nasogastric tube, and they can drink water, take water, and they can comfort. But nasogastric tube in some people can be problematic. Like people who are very elderly, we often see nasogastric tube being in place because they aspirate often and to prevent that. But that's fine. But if you feed them properly, this may be fine. But what we often see is that since the tube is there and patient cannot say anything about whether he's hungry or thirsty, the family kept feeding him on a regular basis, like every 2 hours or 2.5 hours. And out of love or out of compassion, they try to feed him a lot of food. So imagine a patient, elderly man with, or a person with failing system, getting 3 to 4 liters or more in a single day. So it can lead to development of edema or increased secretions or breathlessness, and it actually can contribute to worsening of the symptom. So in such patient, you have a clear advice to the patient on, the carers on how much fluid can be given or what kind of fluid need to be given. So this is one issue we often see with nasogastric tube. Then mask will be there. People use masks very often these days, and many machines, do see many machines in the household these days. Earlier, someone with respiratory failure, they stay in the hospital and often die from the hospital. They hardly come home, or then they come home, they kind of with advanced kind of almost like an near terminal phase. When the family is told that patients are dying, they might bring the patient home. But nowadays, what happened that a lot of machines are available and these are cheap, and some of the machines can be set up at home, like the oxygen concentrator or the BiPAP and CPAP machines. Then they have become so small, and many patients get transported back to the homes with these machines on. So that is another additional area probably need to expertise. So you need someone in the team or who can advise you on how to use these machines or what are things. So this also makes things difficult. So if we have a symptom, a machine at home, and it can be supported the patient using the machine well, that's fine. But if it's a problem, or if it gives errors, or if it is not working well, then you should know how to do. So you probably also need some expertise for these machines in the not someone on regularly visiting you, but someone on a phone, a doctor, someone who can advise you on this use of these machines and on settings. So these are the things that makes the home and this thing different. Basically, the same thing, same medication, or the same interventions, it can also be done at home. But it takes a lot of things on the patient, the team's knowledge and skill. Whether the team have adequate knowledge and skill to do these things at home, and the clarity in communication. How good you are with your communication, like whether you are able to clearly explain all the things that the patient and family need to know for good symptom control at home. And then how do you follow up with that? Then clear management plans, roles, responses, and follow-up plan. It's not that you just advise something and then disappear. Because I told you, like it's an ongoing process. It's a continuous distress for the patient and family. So they should have clear plans on how to follow up this patient, and importantly, documentation. Everything that you do should be properly documented. So it may not be the same team which is following the patient. Suppose you refer a patient to a home which is far away from the hospital. A new team may be taking over the care of the patient. So if you document properly what situation, what are things to be done, and what medication the patient need to be on, all the things in a very clear manner, that helps the second team to provide good symptom control at home. So this is important. So whenever you come back from the home visit, you have to document, you have to discuss about the things that you have done and what next to be done to this patient, or when the next visit will be. All these things will be or if the patient calls up in between, how we are going to kind of manage the patient, whether you are going to make an extra home visit to see the patient, all these things. So this should a clear, active management plan for it. It's not just simple as when putting someone at home and hoping that his symptom control will be good. There's a lot of checks and balance has to be in place to ensure that the patient has remained symptom-free and comfortable at home. I think, yeah, that's all I have to say now. I think we have some time for discussions, and I'm happy to take questions.
Thank you, Anil. Now, Arun will ask you the question. Arun, please go ahead. But Anil, I want to ask you one thing. What sort of music you have arranged for us? One bird. What sort of music? Nice music. A bird is continuously teaching. Bird was there in the background music.
It's morning time. It's for the birds.
Yes. So go ahead, Arun. Arun, please go ahead.
Yeah. Only thing I didn't hear anything because I have that earphones plugged into my ear, so I wasn't hearing it. Okay.
Birds do chee chee. Birds do chee.
Dr. Anil, thank you for the lecture. One question we have: gastrostomy tube care at home. Do you have any advice for that?
Yeah, people do get referred when sent back home with gastrostomy tubes. The issue is that whether you understand what kind of feedings can be given or what kind of complications that can occur with gastro. So that need to be clearly explained. What I see often is that the PEG tube, they are very small. When they go home, they feed whatever is available at home. Like they don't adequate precaution to see whether it actually pass through this tube. So tubes get blocked, and they often come back to hospital because blocked tube. Or they can develop local infection at the insertion site. So these are some of the complications that whenever you send a patient home with a tubing inside, it can be a catheter or a nasogastric tube or a gastrostomy tube or whatever, you should have a clear explanation on why it is there and what they can do with this tube and what they cannot. So if there's a good information, the good clear information available with the patient and the family, very unlikely to do. Earlier, now the tubes are much smaller. Earlier, we used to see patients with a big red Malicot catheter placed in the stomach, and it's very difficult to manipulate them. They are almost like bigger than a pencil, and every time you touch it, patient winces in pain, and it's not easy. So even sometimes those times like almost like a death sentence for the patient. Once they have that big tube in, then they are unlikely to survive. But now, if they have smaller tube or the PEG tube, they survive longer with this tube. And with the right advice and right management at home, only they have to come back to hospital only if there's a big issue like a blocking tube or they need to change the tube because of some reason, then they have to come back to the hospital. Otherwise, they can be managed from home.
Okay, thank you. Next question is about family satisfaction. Do you measure routinely family satisfaction at home care?
We don't measure it using a tool. I think that most home care teams don't measure the family satisfaction, but it's more like a perception that you have when you visit them and when you understand the patient is comfortable, the family is also comfortable. So measuring patient satisfaction routinely, I don't know if it's possible because maybe possible we can develop tools for that. We have tools for that, looking at outcome measures. But it's not, I know most home care service, they don't measure it on a routine basis or a prospective basis. Yeah.
Okay, thank you. The next question is about ascitic fluid. So you mentioned sometimes ascitic fluid tapping is done at home. So how do they dispose of the fluid at home care, particularly suppose the patient is seropositive in those cases?
Yeah, that is an issue. Ideally, you have to explain the procedure very clearly to the patient and the family. And suppose that hepatitis B positive patients, they have to really handle that thing well, whatever fluid you take out of it. The patient cannot go home and you're kind of how to do it at home. Take few precautions like total sterile precaution, all the precaution that you take, like gloves, mask and apron. All the things should be there. Second thing is that when you collect the fluid, you should collect it in a container containing 1% hypochlorite solution. Like if you say a 2-liter container, you should pour 50%, like 1 liter of hypochlorite, freshly prepared, chlorine solution into it, and actually drain that fluid into it, and then dispose it in such a way that it doesn't get, other people don't get, doesn't get a time to touch it or get it under the skin. Like you can flush it down the toilet once it is inactivated or still, once that is done. Or you can, even if it's a, you can, if it is a household has some land, you can take a small a pit in the courtyard and dump it there. That depends. But make sure that every time you do a ascitic fluid tapping, the container in which the fluid is drained has hypochlorite, 50% of hypochlorite solution, 1% solution, or 50% of the container should have that solution, so that the chance of infection is less.
Thank you. Okay. Next question is, sometimes patients are given analgesics and also opioids at home, but the caregivers might have some kind of phobia towards those medication, and the patient doesn't get the medication because of the caregiver's phobia.
Yeah.
How do you manage such a situation at home?
Only thing is that it's a difficult situation, because the only thing that you can do is continuous explanation. Explain it ad nauseum, like just telling them once, it may not be enough. Every time you follow up the patient, you have to tell repeatedly why these medications are given, and then how that can be given, and what are the possible complications, and all of this has to be repeatedly. Some you get irritated, like you get upset because you have told them some 5-10 times, and then still the patient is not getting it. But you don't have no other choice, because the patient is dependent on the family or the person who is giving the medication is kind of rationing the doses. Patient you have no choice, but only to make sure that they really understand. And so that's why I said you invest a lot on the carers, because that are the best team you can get at home, the best you're alive. So tell them, explain to them, do that repeatedly, and that's the only option. Otherwise, it's difficult. Address that concern. They may have some genuine concerns, and if you don't address those concerns, they will continue to behave like this. That's only. So clarity of communication is very important when you want to provide symptom control at home.
Okay. Sometimes patient might develop seizures in their home. How to manage such situation?
That again, I didn't hear that well.
So the question is, sometimes patients might have seizure, like somebody is having some kind of epilepsy, they're on medication, they miss a medication, and they develop breakthrough seizure at home. What advice is given for those
Okay,
patients?
yeah, seizure, it's an emergency. If it is like sometimes the patient will be on a long-term anti-epileptic, still they develop seizure. A patient with seizure has to be controlled as quickly as possible. That is the priority. Sometimes they settle itself, and then the patient seek advice or the family seek advice. Then you have to review the medicines and either increase the dose of medication or add new medication, or if you feel the patient need to be investigated, you can do that. But the issue will be if there's a status epileptic. If the patient is in status, then it's a different situation. Patient needs medications in parenteral administration, and that has to be done quickly. So what we use a lot of midazolam in such situation, either intravenously or subcutaneously. And then once a seizure is controlled, then maintain the patient on a higher dose of anti-epileptics, or refer the patient to a hospital or consult a neurologist and see what else to be done. So seizure is an emergency, and sometimes you may not be able to handle seizures from home, especially if it is status epilepticus. Other seizures, it will settle down, but they'll come back again. But in the meantime, you have to assess the patient and ensure that what's gone wrong, or it can be simply like it may not be anything to do with the brain or something. Maybe anything to do with any brain injury or something. It can be metabolic or some other. So you have to assess the patient and see what to be done next. And if status epilepticus, maybe you can try to control it from home using medications parenterally, and then refer the patient if it is difficult, or if you need a maintenance of parenteral antiepilepticus, you need to refer the patient to a hospital. That's why you need sometimes you need a good backup. It's not that all symptoms will be well controlled from home. A backup is a must for adequate symptom control.
Okay. Thank you. Another question is about waste management. I think this is about waste other than ascitic fluid.
Yeah.
Sometimes you do dressing and other things at home. How do we go for waste management at home after procedures?
It's a big issue. If the patient who has a bit of land around them, then what they do is that they do deep pits and dump all those things in there, like dressing materials or some of the plastic tubings there, and then just dump it. And sometimes they incinerate. But it may not be possible in big cities or where the patient live in flats or apartments. What people do often is to have many cities now have services which collect medical waste. Only thing that they need to be clearly secured. They have to be in an adequate bag. They do collect it and take it. But what we have tried here is that we try to create minimum waste. And if there is some sharps, etc., we advise them how to do it. That if that difficult, and we are now that it's not happening. That now we are thinking about having a system where we actually bring back sharps and other infected materials and then process it in our own way. The Indian Medical Association in Kerala, they have a service called Image, which collect material from the hospitals, not from homes. But we are thinking of availing the service so that we can collect the medical waste that we create from, like if you do interventional thing and then you have a needle or a sharps and you can bring back, then to have, with the help of this team, we can process it and dispose. This one possibility we have. But in our place, it's most of the time it's not a big issue because people have some land around and they dump it there or they burn it outside. That's another issue. But it's an issue. It's a real issue in cities or places where people don't have access to such facilities.
Yes. Okay. One question is about a patient has ascites and are feeding jejunostomy. Now there is a leak around that feeding jejunostomy. What advice can you give for this kind of cases at home?
You say that patient has ascites and jejunostomy.
Feeding jejunostomy, a bit of leakage around that tube of the jejunostomy. How can it be managed at home?
You mean that jejunostomy is leaking?
Yeah, bit of ascitic fluid leakage.
Oh, because of ascitic fluid. Yeah, because that even when you do ascitic strapping with the institution or the home, it's often see that maybe next 1 day or two there can be some leak from the puncture site. That's because of the pressure inside is still high, so it tend to leak. So if there is a ascitic fluid leak through the jejunostomy or any other hole, the best thing would be to remove as much fluid as possible. That's one way of doing it from home. But if it's an issue or if there's something else like a local infection, something, then you need to get an opinion of an expert, like surgeon need to see the patient. But often the reason for leaking from the puncture site is because of the increased pressure within the abdomen. There's some people, they don't take adequate amount of fluid out. They do ascitic fluid tapping, and since it is at home, they may take only 1.5 liters of fluid out. That may give patients some symptom relief, but it's not adequate. So if there's a huge abdomen, there's a lot of fluid inside. If the patient's condition permits, you should try to remove as much as possible, because it's a third space fluid and it's not going to help the patient anyway. It is not part of circulation, so it's only causing it's like an extra thing within the body and causing symptoms. So if the patient general condition permits, you can try removing as much as fluid. Then this kind of leakage will definitely come down. That's what in our experience. Yeah.
Okay, I think last question we'll take. So you mentioned about the container for ascitic fluid tap. Na? How much of hypochlorite solution would you like to put?
It's a 1% solution. It's a 1% solution.
So if a container is
We should take 50%. Like it's a 2 liter container, you pour 1 liter into the container and set it. So 1 liter it can go in. It's equal part. Equal part, same as ascites and sodium hypochlorite, equal part. 1:1. So it's a 1 liter container, then take 500 ml of hypochlorite solution, then take 500 ml of ascites in it.
Okay, thank you. Sushma Madam, 7:30.
So Neil, thank you very much.
Thank
It
you,
was
Sushma.
such a wonderful presentation. So many practical tips you have given. I think everyone who is listening today, I think they've got a lot of hints that how they can manage their patient, and when they get a call from patient that this is happening or that is happening, they will be having a solution. I know this is Anil's presentation gave you a lot of insight and a lot of points, but every patient is different and every situation is going to be different. You will get a very strange queries from home if on your phone. It is basically you should know how to handle the basic principle of handling a patient at home. So keeping all these principles in your mind, you have to tackle the situation differently in every patient. So I hope that this lecture will give you a lot of insight, a lot of basic principles to handle your patients at home, even if you will get a different type of a different type of a query. Before we log off, I want to announce one important thing that on 15th of March, please, you don't have to log in 6:30 in the morning. You have to log in 6:30 in the evening, because on 15th of March, Dr. Tykros will present, and this is a presentation we should not miss. We all know who is Dr. Tykros. Dr. Robert Tykros will be there, but because 6:30 it's midnight for him, I have suggested that it should be at 6:30 in the evening. So please, only for a day, there will be a change in the program that on 15th of March, we will be there at 6:30 in the evening. And I am announcing it long time before, and I will keep on announcing every Monday in the morning this announcement, because there should not be any mistake, and we should not miss this lecture. So please ask your colleagues, your friends, and those who are interested in palliative medicine, as many people as log in. I think this will be a wonderful session, and we are very fortunate that at this age he has agreed to give a presentation on 15th of March. Thank you very much, Anil. Thank you all the audience for joining early morning. More than 100 audience were there, Anil. And thank you, Arun, for keep taking all the questions. There were one or two more questions. I think you can pass on to Anil, and whenever you will get the answer, you can send the answer to Nisha, and Nisha can pass on the answers to the audience who has posed the question. And thank you, Nisha. Thank you for keeping everybody on track. I think whatever is happening on time is all because of Nisha and Arun's efforts, and plus the wonderful speakers, those who are keeping the quality of this series, excellent quality going on. And thank you, Anil. Thank you very much.
Thank you, everyone. Nice meeting you.
Thank you, everyone.
Bye.
Have a nice week. We will see you next Monday, early morning before 6:30.